Good morning, good afternoon, good evening, wherever you may be, to this webinar session in the series focusing on patient experience at hospitals organized by BestDoc. Today, I have with me three leaders, or rather giants, from the Indian healthcare space, with a combined industry experience of more than 8 decades, coming together to share their insights about inpatient experience, an area which has seen renewed focus catalyzed by technological and operational innovation. And no better way to discuss this than with two distinguished guests coming respectively from the technology and operations expertise. Firstly, I would like to introduce Mr. Rajiv Sikka, the Group CIO of Medanta. Mr. Sikka has been instrumental in taking Medanta to where it is right now, leading the digital strategy, both front-facing as well as back-end transformation. Medanta has received national and international acclaim on how it managed the multiple COVID waves in North India. And this is in no small part due to the technological vision and execution strategies undertaken by Mr. Sikka and the team. Welcome, sir. Next, I would like to introduce Mr. Neeraj Lal, the CEO of Apollo Hospitals, currently based in Gujarat. In the 20 plus years of experience in healthcare management, Mr. Lal has been the driving force in scaling numerous hospital groups, including Rainbow Children's Hospital, Medicover, Sunshine Global, and Shalby Hospitals. Focused on operational excellence and quality, Mr. Lal is also a key member of the ISQA International Survey Team for Hospital Accreditation, as well as internal auditor for NABH, NABL, and a member of various national and international quality councils. Welcome, Mr. Lal.
Thank you.
Of course, we have our host for today, Mr. Bharat Gera, strategic advisor for BestDoc and a pioneer in digital transformation of healthcare. Mr. Gera has worked with hospitals across India, including most recently at KIMS Hospitals, Hyderabad, as well as St. John's National Academy of Health Sciences, Bangalore, and has designed and implemented multiple projects for digital healthcare. He is, as I would call, the chief evangelist for patient experience technologies in India. And I would like Bharat to start off with the webinar. Over to you, sir.
Thank you, Mithun. Welcome, Rajiv and Neeraj. He's put us on such a pedestal that now we'll have to live up to the discussion about what can be done about patient experience. And to set the context, I think we're still talking in COVID times. We're still not completely out of the COVID times. And although Mithun talked about the decades of experience we have, I think the last 2 years is equivalent to 2 decades of experience. And everybody has realized how important it is to have operational efficiency in hospitals when beds were not available during the COVID time. And people have realized that how difficult it is for people to spend unnecessary time at the hospitals. How can we make them, at COVID time, nobody could enter the hospitals, right? So it was difficult to manage without attendance, and hospitals found several technology solutions during this period. So the digital transformation expert is not me, certainly. It is, I think, COVID, as we all have acknowledged. What I noticed when the pandemic began, and I was doing study for telemedicine in India, and I found one thing, and over the association with BestDoc also, I found the same thing, that there are laggards who are not able to, reach to be able to deliver a better experience in the hospitals, and there are people who are right in the front. And the reason that happened, that even though all of them were supposed to do the same thing post-COVID or during COVID, some of them, a very large number of them, could not actually cope with it because they didn't have the previous experience of being digital enough or being prepared enough. Like they say, preparation is half the battle won. I'm so glad that we have both of you on this talk, and being the beacons in the industry, who did not start during COVID times, but started much earlier on improving patient experience and operational efficiency at the hospitals. I would really, like to hear how you did it. I'm going to start with Neeraj on this one. Neeraj, you've been at several locations and now you're with Apollo. I would love to hear how you did this over the years. How did you improve operational efficiency and patient experience in hospitals?
Okay, thank you for the question, Bharat. I think you are very right. This pandemic has changed the way we work in healthcare, and healthcare gone for a toss. And I think healthcare is the only company which is working from hospital, unlike all the people who are working from home. So I think it has changed the way we work, and now you can have all the doctors, magnets, and stars. They are available on virtual platform. So because I have seen in this pandemic, I think I was with Medicover, I was with Rainbow, and now finally for last few months I'm working for Apollo in Gujarat. I have seen telemedicine. Apollo started long time back, but somehow it was not happening. The main concept of telemedicine to reach far flung areas. See, like in Rainbow, we got pediatric subspecialist, pediatric neuro, pediatric nephro, and generally if you travel tier 2, tier 3 cities, you don't have all these specialists. We have general pediatrician. So what we have done through our telemedicine network across state of Karnataka, we have telemedicine facilities, key district, where these children used to come to a general pediatrician clinic or a hospital, and our experts sitting at Bangalore in Martali and Banargata Road, they used to interact with the patients through a pediatrician who is available at Shimoga, Dharwad, and so on. So it make the life very easy for them. And once in a month, they're traveling to these places. But I think now, because of this pandemic, I've seen the virtual consultation has gone from less than 5% to 45%. Now, most of the people, see, I always see PGI and AIMS Delhi, they got an OPD of 5,000 patients per day, people coming from far-flung areas. But thanks to pandemic, I think now filtering clinic is happening through this virtual consultation. So you're not coming to the hospital just for the sake of primary consultation. You're getting filtered out through this virtual consultation. And just in case you require a hospital visit, you can come. Like say, for example, in Medicover Hospital in Hyderabad, what we have done, patients are not coming after first wave. So we have carved out our OPD on 50,000 square feet, 200 meters away from the main hospital. We created a OPD block where the patient can come. There is no ICUs, there is no ward. So patients are fine. Health and wellness lounges there, and all the multi-specialty consultants are sitting on the different floor. So you come like a mall. You come, there is a coffee house, there is a health and wellness gymnasium. Go and meet a doctor, get your nutrition checked by your nutritionist, and go away. Just in case you require a indoor admission, there is a battery operated car which is parked there. You sit in that battery operated car, go 200 meters away and get yourself admitted. I think it has changed the way the healthcare work. So now most of the hospitals, they are trying to do OPD block carving out from the main hospital. And for the sampling, we are not actually physically sending the sample. We have done a trial drone. So from the top floor or the fifth floor, a sample has been parked there, and it is flowing all 200 meters away, because you have to take a legal license. So, but we have done this. So it has changed the way we work, and all it is looking like a health city, battery operated car moving from one place to another place, and only for those people who actually require a care in the hospital. So these are the few things which we have done. And as the discussion move forward, I think I'll share some more experience with my children's, women, because newborn vaccination is key. So what you will do, you cannot stop the newborn vaccination. So everybody was calling, when my child require a vaccination, what to do? And they are not coming to the hospital. So instead of all the people coming to the hospital, we have tied up with various clubhouses of the apartment in Whitefield area of Bangalore. Our team of 2 people used to go to the clubhouses based on the appointment given to the parents. They come down, we give the vaccine, and they go home. So all those things we have done, some through like vaccination, you're talking about technology. We have done 40,000 vaccination, in a single day. And there's no need for documentation, just a boarding pass. You come, your boarding pass is scanned, you go inside the hall, get your vaccination, and within 5 minutes you're out. So these are the few things which we have done in first wave of pandemic, second wave of pandemic, and third is on.
Fantastic. Thanks for sharing these really forward, and concrete examples of how you've improved patient experience. I really loved the way you brought in both the digital technology and the physical. So it's a phygital world going forward. And
Yeah.
you're already doing it. It's excellent to
Yes.
hear that.
Yes.
Rajiv, I would like to go over to you and hear from you. You've done a lot during the last few years at Medanta, and I'm sure earlier as well. But I'd really love to hear about Medanta is always known in the industry as the one who provides a 5-star experience. So I'd really love to see how you achieved that. Love to hear that. Thank you.
Sure. So, couple of points, and they may not be very structured, but I'll go through this part. See, I came from a totally different background, and Medanta healthcare is my first such exposure in the India context. So when I joined, people asked me, why don't you come with a digital strategy for hospital? I said, I don't understand digital, I don't understand strategy, and digital strategy is definitely a bouncer for me. So let's understand that what a patient needs, and let's list down in a typical whiteboarding exercise that what are the typical basic needs of the patient. So definitely we realize that their prescriptions, their discharge notes, their lab reports, their radiology reports, their CDs, all of these are very important. And they need it not just for a second opinion, but sometimes, in case of an emergency, the patient is not around Medanta, they should have this digitally ready for the actual clinical needs. So definitely each and everything came. So, within a year, each and every patient records are there on the mobile, which means that they have a doctor portability, they have a hospital portability. And that's what the basic essence of NDHM is, that you don't have to be captive of a doctor. I think we'll go a long way in this. Second thing, one thing which I realized, and that's coming from my mom and my dadi ma, that in this particular industry, trust is everything. This is a trust industry. This is not a clinical industry. It's an art. So that's how the trust gets developed. So, and why trust becomes important, at that time I was not aware that why trust is important. But now I realize that if the patient is engaged, they will take their own calls. They will ask more information. They will be more equipped to take some decisions in their own health, and will be better satisfied, and there are definitely better health outcomes. So what we realize is that in a typical hospital interaction, patient has more than 100 touch points covering both digital and physical. They start not even when the patient has yet to reach the hospitals. What it means is that they will figure it out, what this doctor is, what kind of accreditation this hospital has, what kind of treatment this hospital provides, what kind of infrastructure this hospital has. Uh, this is a fact. I was somewhere outside the country for an operational tour, which was someone told me that God knows, what kind of hospital Vedanta would be, or any hospital in a developing nation like India. And so, it kind of hurt me. So we decided, you said, Bharat, that it's a 5-star experience, and then somebody asking, about the basics, whether the basics would be there or not. So we decided that we'll put a 3D view, 360 3D view of Medanta on the website, which means that, right from the Google Maps, you download, you go down, you figure it out how the lobby is, how my CT rooms looks like, how my OT looks like, how my suite looks like, how my cafe looks like. We put a lot of videos on the website. The journey of a plate from the kitchen to the bedside. We put a video showing importance of laundry in any typical hospital. And it's just such a popular videos. They get super hits. So what we realize is that these are the basic stuff to bring the trust. And then journey never ended. Uh, COVID definitely extended this, but these were already there in Vedanta, and obviously those got further calibrated in the contactless or remote or digital. For me, COVID is contactless, it's nothing but remote, and remote for me is nothing but digital. So these are like quite synonymous for me. And right from appointment booking to asking for bill payment mechanism, to get a receipt, to get a prescription, everything is on this digital world. And then uh, that's one part of the OPD journey. And I'll take a pause here, and we'll rattle more such experiences as we move forward.
Superb. Thank you, Rajiv. I think what I really liked was the 100 touch points you spoke about. We've got some of those identified in the IP patient journey here on the slide that Mithun has shared. Um, it's really the way to do it, what you said, identify all the touch points, see where the moments of truth lie in those touch points, and try to see how much it can be made an excellent patient experience. Um, Somewhere I read that if you're trying to do Six Sigma in any industry, um, you need to look at not just your core activities, which is the provision of the healthcare, the curative part of it, but 80% of where the inefficiencies lie are in the non-core activities, which is like moving the patient from one place to the other, which you both spoke about. And I really love the battery operated cars taking them. I know what a nightmare it is when somebody has to be admitted and they're waiting in between the OPD, and taking them away from the OPD area. Brilliant way to do it. So now the 80%, as I was saying, which is, and Rajiv also spoke about one thing which my friend Ambrish Gilyar often mentions in his LinkedIn posts, which is about, it's, if you have to get this right, you have to do 3 E's: experience, engagement, and empowerment. Rajiv, from his personal background, shared that as well, that you need to build that trust, and that trust will come when you get the patient more engaged and you're empowering them, and then providing them, of course, a great experience as well. Um, Now, what I have seen is that in spite of all the best efforts that people make in hospitals, there is still a lot of vast area for improvement. I make, maybe a little bit of a controversial statement, but I think a lot of hospitals, I'm not sure about Medanta and Apollo, but a lot of hospitals I've come across, they have this so-called VIP category. And my thing is, in this time and age, there's no VIP category. Every patient is a VIP. Every customer has to be a VIP. It also, it sort of admits that we can't do really well for all the others, right? That's one thing I find strange in today's time in hospitals. And the other thing is, there are these really tricky problems, and I'm really fortunate in this forum to have a leader from technology and from the operations side at the table. I wanted to put this across. So many times, there are these sticky problems, like the queues that happen in pharmacy, or the time it takes to make a lab procedure done. Especially radiology, I've seen a lot of times, the long waiting periods for radiology investigations. These are sticky problems we see across when we speak to hospitals. And of course, the inpatient part, where I just, when I work in hospitals, I just go and talk to patients. And several times I've heard things like, सब ठीक था, लेकिन जब nurse को बुलाओ तो कम से कम 8-10 minute बाद आती थी. So, I could not get the bedpan in time. So these are quality indicators, and sometimes there is a gap between how technology sees it and what operation sees it as. So this time I'd like to start with Rajiv, that what gaps have you seen and how have you overcome those challenges?
Sure. And I'll not disagree with you that there are definitive gaps in each and every operation, because the scale is too much. And what we realize is that the scale at which Vedanta operates, we also have roughly more than 3,000 OPDs per day. So which is a huge number by all means. And someone calls it private aims. So, so now what happens is that I'll typical activity which are done, and these are some of the best practices which we picked up from the other industry verticals. We started doing a very strong digital survey. We said that we will try to be away from the paper surveys, because then God knows who's filling it, and whether it is full or half. So at the end of the each encounter or visit or interaction, a automatic link goes to the guy and he fills. And we realized that there are two major problems which are coming up in the complaints. One is the discharge part, which everybody knows that is a major challenge. And the second is the food, both in terms of TAT as well as in terms of quality. Sorry, in terms of hot. If somebody has asked for a hot food analysis, so these were the two major challenges. There were challenges in other areas also, and some we were able to, very easily able to do it. I'll give you the third biggest example was that we have a 15 floor hospital, a 21 lakh square feet area, and the billing area is in the lower basement, is in the lower ground, which means that who's in the 15th floor has to come all the way to 16 floors down and do the payment. So and sometimes patient's attendant is also relatively old and they can't go each time to get payments done. So there was a simple request: can't we get a link to pay? Which means that, and we all know that this is very simple. This doesn't need any tech. Only stuff is that all those will be to be treated as advances and to be integrated in the billing system. So that was very simple tech. So I keep saying tech is never attractive, tech is never complex. Its usage, its applicability is more important. So this was like a 2-day job, integrated into the billing and get it done. So, but let's go back to the discharge. Now what happens is that Dr. Saab is on the round, and in the morning at 9 o'clock, he says that, we'll discharge you today. So patient, all back set. By 9:30, he's expecting that I will, go and do the final billing and I will be discharged. So in this particular case, as we know that there are multiple departments who are involved, right from the, labs and radiology whose tests are still pending, or medicines to be returned, or TPA information has to be sent. So what we did is that we requested doctors and doctor teams that own the mobile app, which is for a doctor, they have to just say announce discharge. So at 9 o'clock, he says on the click of a button, announce discharge. Then each and every workflow gets triggered. What we have is a live dashboard in each department head, including housekeeping. He knows that this particular bed has to be vacated. Expected time is this, because we have measured each and everything. Nursing department is aware. Clinical pharmacy department is aware what medicine has to be returned. So there is a dashboard. Everybody is fully aware. And at 2:30, medical director asks for whichever areas which are in red or in yellow, because it's automatic calculation of the dashboard. And then questions are asked. We realize that if questions are asked, things will fall in place within 1 week or 2 weeks. And now we have been able to reduce cash patient discharge to the expected TAT, which is like, very, very wonderful. It is not about, yet it is bed inventory. But if you ask me and ask Vedanta, anyone, it is about patient satisfaction. We don't have mainly we don't have a possibility of cash bed, but we do have, this patient dissatisfaction, which is at very highest level because of bed discharge. This is one part. It's a simple dashboard, and each and every point. So I'll give you an example. The major problem used to be that somebody is taking a discharge summary to the billing counter, and nurse says that I have given the discharge summary. Billing counter says we have never received it. So no trust on anybody. We trust in only tech. Like, people trust in God, we trust in tech. So in this particular case, the guy who's taking the discharge summary, there is a barcode. He has to, from the nursing counter, the GD has to scan it. So it gets recorded that I have started at 11:10 from the nursing counter. He goes to the billing counter, he scan it one more time. There is a barcode reader there. So I know that at 11:10 he started, at 11:18 he has delivered that discharge summary. So all the manual calculations, movements have been, same thing with the pharmacy returns. The guy picks it from the pharmacy nursing unit and deliver it to the main store for return. Both the movements are tracked through the barcode reader. These are nothing high tech, very, very simple tech. And, roughly 250 odd discharges are now completely automated. Each and every milestone is fully automated. So this is an assistance to ops, because ops, is struggling with this when the GDA started and when the GDA reached. So, I thought I'll share some of these examples. Same is with food. We have, as soon as the food order we have roughly 28,000 items, 2,800 items get delivered in the room. And as soon as someone orders it, it gets logged through a ticket in the system. And as soon as the plate moves from the kitchen, again the scan happens, reaches, he has to scan it. So journey is tracked. I can't comment on the quality of the food, but I can definitely comment on the serviceability of the food. So that's what we did in some of the basic experience for the patient.
I love the way Rajiv makes it all, keep it simple and stupid principle. Don't complexify it, because then you're going to run into more obstacles. And a very smart way of handling the problems that are there typically in the healthcare industry, especially the tracking part you spoke about. I want Neeraj to step in now and share from, where does he see the gaps when he's working with the technology team, or and if when you face those gaps, how did you address them?
Okay, I was just seeing the slides while Rajiv was talking, the feedback which patient gives. See, a small thing, like we have a nurse call management system. So I don't know why the name is nurse call management system, because poor girl has to be called for anything and everything in the hospital. My AC is not working. I'm not getting food on time. If you see these feedback also, they're not talking about clinical services. They're talking about the supportive services. So what we have done in Bangalore in one of the hospital, instead of a nurse call bell system, we have installed a 4-point care. So we have a housekeeping button on it. It is a Wi-Fi device which we use to give to the patients. Housekeeping, maintenance, F&B, as well as a nurse. So if I'm in the patient bed and I require a food which is not coming, or I may require something maintenance part of it, or a bed sheet or a cushion. So instead of calling a nurse, I press housekeeping button. Automatically a alarm goes to a housekeeping supervisor of that floor with a TAT, defined TAT. We have mentioned the TAT within 5 minutes, within 10 minutes, within 8 minutes. And he need to revert back with a patient room and closure. He can come to the room and close the call. And once it is satisfied, then only you can close it. So, and if he's not attending with the phone call, this message goes to the CEO or a manager of that unit. So we, at the end of the day, we can manage how many calls are raised from the patient room and how many has been closed. And we have seen two things happen, major thing. One, patient satisfaction has gone highest, because now we are maintaining TATs, and if you're not doing, it is escalation going to a manager or a CEO or a unit head of the hospital, number one. Secondly, a poor staff nurse, 33% of time was saved, because we have used these 4 buttons. We have categorized, we have done a traffic man job. You go there, everything don't go to a staff nurse, and it changed the way we work. And I presented in the budget, okay, there is no shortage of staff nurses, because she doctor comes, she has to accompany, patient require medicine, she has to accompany. So with this 4-point call system, which is a small Wi-Fi device, one startup company, small 2-3 young boys came and he made it for us, and we've installed. And regarding the cost of it, we are billing just 110 rupees per patient for his entire stay, and he's so happy. Number one. Secondly, when I was working in a pediatric hospital, it is very difficult for the children to wait for the consultation while doctor is busy in consultation. Very difficult for parents. So what we have done, we have installed a floor mounting game device on the waiting area of the pediatric OPD. So while they're waiting for the doctor to consult, so there is a device on the top floor, on the rooftop, and some games are there on the floor. So the children used to play, they play football, they hit the football. It is all virtual game. So children become so engaged with those games, and parents have to literally take them out. Your turn has come. We have to go in. So it is so nice. So I've seen in one of the meeting when I was talking to this apartment resident welfare association, okay, my children say, okay, Papa, we need to go to that hospital because there is a games there. And generally, if you bring the children to the hospital, it is a nightmare for the parents. So small things I'm talking about, like you're talking about this patient care, a health checkup, Apollo drive health checkup in a big way. We say Apollo Pro health checkup. Earlier it was Apollo Master health checkup, now Apollo Pro health checkup. So in city of Ahmedabad, what we have done, big corporates go for a health checkup. I think everybody can go for a health checkup wherever you want, but how it is managed and how it is linked to your profile. So what we have done in the last few months, whichever health checkup we have done, or Torrent or any pharmaceutical companies, we have created a AI dashboard for them. So after the health checkups, we send that AI dashboard to them. So what we say, 600 employees screen. It is in the form of a bar graph. It is something like this. So what we send, 601 employees get health checkup, 80% having NCDs, 37% and more than one comorbidity, 23% with NCD in the age group of 46 to 60, hypertension and so on. And that HR manager and the CMO of that corporate is so happy, because health checkup is what you send the file and they don't know what to do with that file with some report. So we have given a AI based summary, and a health mentor is attached to each of the employee. So when I get to know out of so many employees, that many NCDs, that many hypertension, there's many comorbid conditions, so that you can take a call accordingly. And since then, we are getting health checkup from that corporate on a continuous basis. So we are empowering the corporate. We are making the journey of patients, maybe children, maybe adult, so well. So they are thinking more about how to access that facility and use of technology. So few things what we have done, and it is working well. Like in one of the hospital in Medicover, which I think Rajiv knows, I was sharing, there is everywhere you have to do punch in and punch out. And it is very, very difficult for the doctors to ask them to punch in, because he is available omnipresent in the hospital for 24 hours. Punching is not, it is very, very important. So we have AI based cameras. So whenever you're coming, you're not supposed to punch in. You have to just see the KI. You have to just see the cameras and go away. And it also check your happiness index. Say, for example, in the morning, Bharat is coming to the hospital and he's 75% happy. While he's going out, we have seen it is 47% happiness. Then you may get a call from HR manager. Hey, Bharat, you are not very happy as you came in the morning with 76% happiness and you are going with just 45. What happened? The day was not good. Something like this. And, cameras, which is put up in the OPD, a patient is waiting. So we see a sad face in the AI camera. Our customer care manager approached to that patient who is waiting the OPD. I understand you're not very happy. You are sad. How can I help you? So if you use all these technologies, patient feel, oh, somebody's watching me for a call. Then he say, I'm waiting for the doctor. He has not come. There is a billing, which is I'm not happy with. All those things we can track, and we can check the patient moods and their happiness index by using technology. I think it can change the way we work in the healthcare.
Amazing examples. And I love the way that you work with startup companies. And as you know, I'm associated with startup companies, including BestDoc, trying to do similar things, and others as well. I think the technology innovation that hospitals need increasingly is coming from young startups, which are very nimble and able to deliver what you need. In that light, I wanted to bring up, what are we heading for? And I'm taking a 10-year perspective on this, or at least now 8 years. So 2 years have already gone. So I'm looking at 2030, as the time frame. And what seems to be happening here is that with the National Health Authority and the ABDM and the Unified Health Interface, we are headed towards a much stronger ecosystem than ever was. And like Rajiv was talking about, and you were talking about, we can make life much easier for patients to move between facilities and go from one hospital to the other, from one lab to the other. People are saying that this is like the UPI moment. We are at the beginning of the UPI movement in healthcare, which coincidentally, it's the same team and they've called it UHI, and we're heading for the UHI moment, which will fructify over the coming years. So that is one trend I see for the future, which is very specific to India. But then globally, the trend is towards consumerization of healthcare, where the customer is asking for convenience, transparency, and also being able to, be able to discover, of course, and also be able to be involved in the decisions. They are not letting somebody tell them what to do. If you take the surgery market, for example, Pristine has been creating waves in it because they have been able to, like you just spoke about, a mentor for every patient. I think that's where we're going, where the level of service requirement, um, pre-hospitalization, post-hospitalization, during hospitalization, there's going to be much more involvement of patient as a customer. So both these trends will sort of merge in the coming years is what I feel. And I'd like to hear from both of you on how you're preparing for it and what do you see as your role in the ecosystem in the healthcare as it is going to fall in place. So maybe we can start with Neeraj again this time on this one. Yeah.
Okay, I think you are very right. This technology is coming, and I think pandemic is a biggest enzyme to change the thing we think. I'll give you example. Now, most of the time, if you see any hospital planner earlier, 10 years down the line, ICU beds is generally 15 to 20% of the total bed what you have. Say, for example, if you are having a 100-bedded hospital, you have 15 to 20 beds. Now, if you see 30-40% bed in any hospital are ICU beds. So I think we don't require a hospital for any small time thing. We require a hospital for a critical care, for a procedure or a surgery. This pristine model, or so many companies, they have come with a different kind of model. What they're talking about, they require a hospital only for an operation or a surgery or a critical care. And I think COVID have exposed the entire hospitals. See, we are looking for a bed with a ventilator and oxygen, which is in shortage. So if we make hospital in the way, it is more critical care bed, more OR, it is much better. Secondly, from the OPD point of view, see the challenges. So like Apollo, what we have done care suite persona. So what is talk about? So many data is generated while patient is coming for outpatient. So what we have done, challenges with paper-based prescription. We cannot track the investigation which is ordered by a consultant. Admission, surgery, procedure advice, we cannot able to track. Medicine ordered, we don't know. So I, as a CEO, as an operating head, my responsibility is P&L also apart from a patient care. So while doctor talk to the patient, he write the prescription. And I think the prescription of a doctor can be read by doctor himself or herself or a pharmacist only. It is very difficult. So we have started the CSR, which is care suite persona. In this, we have linked our appointment system and HIMS to this. So whenever a patient is going inside the patient consultation room, doctors spend most time by talking to the patient, hear them out what is happening, and automatically a specialty based templates are there. So accordingly, he can also make the flow diagrams if he's explaining certain GI route or whatever routes, right? So a video will come which will talk about what is happening in the body, what can be done and all. So it is template driven and it can be modified with minimum clicks. And whenever he's ordering a pathology or a radiology or a procedure, it is somewhere stored. So that whenever patient is coming out, he's not coming with a prescription. He's coming with an e-prescription. Then a care manager will assist him or her, take them to the pathology, take them to the radiology for various tests, and while he's going out, most of the time pharmacy is outside the hospital. He can take his bag from the pharmacy, just pay them and go away. And there, he's not supposed to show the prescription, stand in a particular queue and all. And with that e-prescription, we can able to track when next pathology can be done, when next procedure is planned. So OP to IP conversion, I think if you see, it is not happening in most of the hospital. So we used to take care through CSP platform, where we are tracking entire OPD based prescription, and it makes the patient journey very smooth. So whenever he entered to a doctor room, you must have seen he's coming up big poly bag. Like few days back, Governor of Gujarat, he comes to our hospital to show to a ENT surgeon. And I'm seeing the medical officer which is attached to him, he's bringing 5 bags, CT scan, MRI, reports and all. So I was just talking to him. So instead of that, if he just come walk like that, and there is a UHID number where our doctor clicks, like what Government of India is planning to do, entire CT scan, MRI and pathology and radiology can be seen, and then an e-prescription is generated so that we can track the entire patient journey in OP or IP. So we are attempting to do that. We are
I've noticed that
fine.
Apollo is one of the 27 organizations that have been certified by the National Health Authority on the NHA platform. So
Yeah.
that's really a big achievement. So going
Yeah.
forward, we will be seeing a possibility. There's a very simple thing I've asked people. What can be taken up first? As a patient, what I find is that the fact that I go from one branch to another branch of the same hospital chain, I have to go and register again. I
Yes.
said, at least let's solve that problem. Why do you want the patient to pay for registration each time? One ID across all the hospitals should work
Across all
without
those.
this
Yes.
registration. I mean, it's
Yes.
a very low hanging fruit problem, but it's not a huge problem. But 200 rupees across 200, 20 million people, it's going to be a lot.
And it's a pain also. It's a pain
Yeah,
also. While you go everywhere, they ask your name, your address, and all.
yeah,
So it is
yeah.
just wastage of time.
Yeah. I've been pushing the hospital industry to adopt digital health ID just for this one reason, that you'll make the patients and your effort lesser by doing that.
Yeah.
Yeah. Rajiv, love to hear your take on this. That how are things going with the ABDM at Medanta, and how are you approaching this whole consumerization wave?
Sure. So two aspects. One on the uh, Ayushman Bharat or NDHM, and second is on the consumers. So first of all, I think it's very clear that in last 75 years of journey of independent India, each and every policymaker have thought about healthcare as inclusive, affordable, accessible, and this has not changed. This is the basic ingredient which is constant across each and every policy we have come in the healthcare space. Now, and why it is important is that this is also a reflection of the consumer. See what happens when the patient moves, as rightly said by Negaji, that we don't want them to have repeated tests from one location, because those tests should be available to to the newer hospital, to the other hospital on a click of a button. Now it will help uh, a repeated test, which is a cost, and also all the delay which happens in getting this test done. The other part, so what we have started doing is that we have a legacy product which is now getting integrated. My 99.9% hope is that within this month of March, we already done sandbox testing uh, with the National Health Authority servers. Hopefully, we'll be going live with phase one in this month itself. So that's for us. You know, since we don't have the legacy of brownfield, and our all the hospitals are relatively newer hospitals. They came in last 5 years. So I started from scratch for all of these hospitals, so which means that I have the liberty of thinking about the integration right from the day one. So we have one patient ID which is used across, and it gets synced to other platforms within 30 minutes. So that's a batch job which runs in 30 minutes and makes sure that patient records are synced across locations. So that's
Oh,
already
fantastic.
there. Yeah, so
Fantastic.
that's already, yeah. So now what happens is that now uh, I'm when we think, yet we are not in the public health, but we are of the strong opinion that uh, if this NDHM or this particular uh, patient repository with respect to their disease pattern is recorded properly, what we have is a demography pattern. We have a disease pattern. Now just imagine that you will allocate budget, because disease pattern is not common or consistent across the country. So your budget allocation, your policy definitions, your enforcement of all of these policies towards the disease management will be very, very focused and sort of generic. And you will be working on the very precise data that, this belt in Punjab is cancer prone for this particular area. This belt in Jharkhand is, having lung issues because of the coal mines and so on and so forth. So that's what, according to me, should be the next phase of NDHM and all the hospitals. And just imagine, if I know that this particular belt is cancer prone, better to put more cancer focused uh, infrastructure in that area, better to put more, respiratory focused infrastructure in that area. So that's the ultimate aim, which will be happening in form of a consumerism as far as private payers are concerned. That's my focus. So that's my thought process, and that's what we are also now getting integrated with NDHM's National Health Mission.
So you brought out the socioeconomic indicators of health as being very important for population health, and how ABDM will play a big role in making that happen. And also you spoke about how You are almost there to go live with the ABDM platform as well. Wonderful, and that's what was expected out of the leadership. The leaders in the bandwagon in healthcare from India, and I'm glad you're keeping all this in mind for the future. I think a lot of other hospitals will learn from the thoughts you shared in this seminar. Um, I have just one last concluding point, which I wanted both of you to summarize all the discussion as well. Um, I have personally believed for quite some time that the ones who can change this healthcare delivery in India will be the incumbents. That is, people who are already in healthcare and not necessarily the digital health players who are emerging who have no background in healthcare. Um, People have spoken about disruption of healthcare by, you know, these kind of companies for some time, but we've seen it not really succeed. I feel that trust and the phygital nature of what needs to be done in healthcare doesn't give doesn't allow only a digital only kind of player to play to make a success and to really improve things. And I believe it's organizations like Apollo, Narayana, Kim's hospital, which I'm associated with, and Medanta and Max and Fortis. I think, and including the other 10,000 smaller hospitals that are there. I think all of them can play a big role. If technology interlinks them, they will be able to provide an overall great experience across the ecosystem, not just in their own hospital. Those are my concluding thoughts, but I'd love to hear from both of you on the concluding thoughts. Rajiv, if you could go first, just to make a takeaway from what we discussed so far.
So, there are three things according to me, which will hopefully, I'm not talking of 10 years down the line or 5 years, I'm talking of 1 or 2 years down the line, because we now know that how things have fast-tracked in last 2 years. Mobile will definitely play mobility will play an important role in many things to come. Why? Because we realize that it is not possible for any hospital to accommodate all the possible patients, not just in India. We have seen this trend worldwide. So care away from the hospital is definitely going to play an important role. And as you rightly said, that hospitals have realized that we have all the requisite infrastructure, knowledge, process, skill, and for us to move is better instead of some digital company to start opening a hospital. So that mindset is already there in most of the hospitals, and that's why I say that mobility is going to play an important role in days to come. Second thing, which according to me is very important in this case, is that, and that's my personal experience of doing things in last 3 ways, that done is better than perfect. Don't wait for perfection. And I sincerely share these examples, and this is probably my best accomplishments in my 3 decades of tech experiences. On a Saturday, we were told that Government of India have announced that you start treating patients at home, which are with asymptomatic or less symptoms. This is the first phase. And we were with the civil surgeon's office, and nobody knows what to do. But this was Saturday afternoon, and Monday morning we were up and running, with a platform where patients get enrolled. They pay remotely. They get all the complete schedule of their appointments, interventions. They record their vitals in a particular platform, and any up or below thresholds, alert goes to nurse, or if it is beyond a threshold, it goes to a doctor, and intervention starts. And any emergency, ambulance goes, bring the patient back to the hospital. So much of confidence, in a very simple HTML-based technology. Nobody understands whether it's a high-end sexy tech or it's a simple HTML. But it started functioning like anything. So what I'm saying is that, in a typical environment, I could have perfected this system for months and months before launching it. So, this is a learning, that do it and make sure that things happens and you are able to reach out to maximum number of patients away from the hospital. That's, according to me, would be the new trends in months to come.
Thank you, Rajiv. I love the word done. Done is much better than being perfect. Totally agree with you on that. Yeah. Neeraj, concluding remarks from your side, please.
Yeah, I think he's very right. I think hospitals are not only meant for waiting for the patient to come in. What he's talking about, there is no formal government order here in Gujarat, but what we have done, all the big corporates who have employee strength of 5,000, 10,000, like Gautam Adani Group, Torrent, and ONGC, we have started a Apollo Home Healthcare. So what we have done, we have created a digital team, few staff nurses and medical officers. They're digital nurse and digital medical officers. So we have empaneled with them. We have empaneled with them whenever any of your employee is getting symptoms or they're not well. So no need to come to the hospital. Take an appointment from the team. They'll see you, and accordingly a medicine is prescribed and it will come to your home. If you require certain pathology, and our fellow botanists will come and do that needful. And once in a day, our doctor will see you. So I have seen 10% of the people are on the home healthcare, not only because of COVID, whatever is happening to you, their boss, their mother, their father, their grandfather, who is very difficult for them to move. And whenever our doctor feel that they require a hospitalization, our ambulance will go and bring these people back home. Since I'm a part of Quality Council of India as well as ISCO, I visit other countries. So we don't have a geriatric center. We don't have a pediatric centers. I think one of the biggest hospitals in the world are mother and child, but unfortunately in our country, we don't have one. So therefore, I think now care is going home. So we started a campaign, We Are Coming Home. And through this campaign, we say, don't come to the hospital. Come only when our care team says you require a hospitalization. So I think it is a buzzword. I think hospitals should not be overcrowded with the patients. And you are getting business also, because we are the private sector. We have to take care of business. So now 8 corporates I have seen in the last few months are on the panel of home healthcare. And I think 30-40 patients are on that care team. And out of them, and their patient engagement is there while they are not in the hospital. So I think it is a way forward and we should move forward.
Excellent. I think it reminds me of the statement, the patient will see you now. So, absolutely. Wonderful discussion. Thank you so much, both Rajiv and Neeraj, for making this happen. And we will continue to exchange thoughts on this. And once we get the responses, we will also share with you about what is the response of people. And if they have any further questions, we'll come back to you. Thank you, Mithun. Over to you.
Thank you.
Thanks once again. A really interesting session, especially many of the best practices and examples. Really great to see. I mean, and also I think, I've been working in various other industries as well. Always they used to say healthcare was one of the laggards in terms of digital adoption. But as you see today, right? I mean, what we have seen, especially 2 years or even in this for past few quarters, it's amazing, right? The speed at which we have adopted these technologies. I'm sure like now we can really see that healthcare has gone leaps and bounds in terms of digital transformation and synergizing that with operational excellence, right?
After this seminar, I'm going to cut down my process of vision. No longer vision 2030, at least come down to 2025, because there's so much being done at such a rapid pace by leaders, and others should also speed up.
We are making budget now. Most of the budget for the marketing is going digital way. So you have to spend more on digital. So it is a good sign. So you are very right. From 2030 to 2025.
Thank you, Neeraj.
Once again, thank you so much, Mr. Rajishika and Mr. Neeraj Lal. And Bharat, thanks once again.
Thank you so much.
Thank you.
Bye-bye.
Bye-bye.